transplantation in multiple myeloma is what are the basic principles of this hematopoietic stem cell transplantation that we are talking about. So it's basically high doses of chemo or radiation therapy to eradicate the underlying disease in the bone marrow. And this high-dose therapy not only kills the malignant cells, but it may also ablate the hematopoietic and the immune system of the patient. But the intravenous infusion of hematopoietic stem cells, or HSCs, help to reestablish the hematopoietic and immune system. So the net effect, the final effect, is that this chemotherapy would hopefully completely eliminate the cancer cells, and the stem cells will rebuild the normal blood and immune system. The therapeutic effect of autologous stem cell transplant, which is what we will be talking about, because we also have an allogeneic transplant where the stem cells come from a donor, which is rarely used in myeloma. But for autologous transplant, the benefit mainly comes from the intensity of chemotherapy or chemo plus radiation therapy. So with that, let's see. So this slide summarizes, it's a historic context. So I'm here highlighting two studies from MD Anderson. The first one on the left is a paper in Blood in 1986 from legendary Dr. Bart Barloghi, one of the pioneers of multiple myeloma treatment, when he was at MD Anderson, and he published a paper in 23 patients with multiple myeloma, advanced disease, who received high-dose melphalan followed by autologous stem cells. It was one of the first papers using high-dose melphalan and auto transplant. And the median progression-free survival in these heavily pretreated patients was 4 months. And here is our study from 2019, which we published in Lancet Hematology, where we compared a conditioning regimen or a preparative regimen of busulfan plus melphalan, followed by autologous stem cell transplant to melphalan alone. And in this, although these were newly diagnosed patients who had only received induction treatment, the median progression-free survival was more than 5 years, or 64.7 months. So a lot of progress in these 30 plus years. Basically, the same has been seen outside of MD Anderson and the outside world as well, that there has been a steady improvement in progression-free survival and overall survival with treatment in general. And of course, autologous stem cell transplant has been part of that treatment. So I am going to highlight a couple of studies. The first randomized trial of transplant versus no transplant that was published in New England Journal of Medicine in 1996, led by Dr. Michel et al., showed the median progression-free survival in those who received an autologous stem cell transplant was 28 months, and median overall survival was less than 5 years. And again, we come to 2022, and this is last year. Dr. Paul Richardson from Dana-Farber reported the results of the determination trial, where patients received VRD induction, autologous transplant, VRD consolidation, and lenalidomide maintenance versus VRD for 8 cycles followed by maintenance. And those who received an autologous stem cell transplant upfront, the median progression-free survival was 68 months, so more than 5.5 years. This is more than the life expectancy in that original study in 1996. An average myeloma patient today, one can safely say, has a life expectancy of more than a decade. And in this trial, the 5-year overall survival was 80%, while in this study from 1996, the median survival was less than 5 years. So again, highlighting the great progress that has been made in the treatment of multiple myeloma. But again, it's not just due to one thing or not just due to transplant, but high-dose melphalan and autologous stem cell transplant has been an important part of that therapeutic. So one question that I get asked by my colleagues, my patients and friends, that why do I need high-dose chemotherapy and autologous stem cell transplant today when we have so many different options? So, of course, it's a big debate, but I'm going to highlight just a few important points. One, that it is safe. We know that the toxicity is quite predictable, and treatment-related mortality at any center that that transplant myeloma patients is less than 1 year. And this is also seen in data from the registries. High-dose chemotherapy and transplant in combination with standard induction and post-transplant maintenance treatment is associated with higher complete response rates and higher and deeper responses, including minimal residual disease negative status, which is the goal of achieving the depth of response in myeloma. And we'll talk about this in subsequent slides. And then these responses are durable. So most of the studies, or almost all of the studies, have shown that patients who get stem cell transplant with their conventional treatment have longer progression-free survival. And in some of the studies, there is also a longer overall survival. And another important point is the quality of life, because again, eventually what we want for our patients or for ourselves is to live longer and live better. So some trials have shown improvement in overall survival, and those that have looked at quality of life in transplant patients have shown either similar or better. So again, these are the reasons why it is still a relevant treatment. And then it may still be used as a platform for immunotherapy using T lymphocytes or NK cells or bispecific antibodies, because at least so far, none of the treatments that we have used has universally resulted in cure. There may be a small fraction of myeloma patients that we may be curing, but for the overwhelming majority, there is no cure, and we try to employ everything that we have to achieve as deep a response and as durable a response as possible. So to highlight that point, that this is relevant even today, I will basically summarize a couple of clinical trials that were done within the last decade, and they were done in this era of so-called novel therapy, which is not novel anymore. These drugs have been around now for almost 2 decades, but both trials were from Italy, and in both trials they used lenalidomide and dexamethasone as induction, followed by autologous stem cell transplant, and compared it to non-transplant regimen where patients received lenalidomide and dexamethasone, followed by some different combination, melphalan, prednisone, and lenalidomide in this one, and Cytoxan, lenalidomide, and dexamethasone in the other. And in both these studies, patients who received stem cell transplant had a better complete response rate. And more importantly, both of them showed longer progression-free survival in the transplant group. And in this situation where lenalidomide and dexamethasone was used, or lenalidomide-based consolidation was used, there was an improvement in overall survival also. So patients lived longer, those who had upfront transplant. So even in the era of novel therapy, there are clinical trials that have shown that not doing the transplant reduces overall survival. Granted, these trials were not done with 3-drug regimen, which are more common, and we will talk about them in the coming slides. But again, highlighting the fact that even within the last decade, patients who had an autologous transplant in phase 3 trial basically had the benefit. So again, I am showing a slide that summarizes the guidelines, the algorithm for newly diagnosed myeloma patient. And this is from up to date. And Dr. Shaji Kumar and Dr. Vincent Rajkumar, who are both myeloma experts in Mayo Clinic, wrote that chapter or edited the chapter. And this basically summarizes how to treat a newly diagnosed myeloma patient, whether transplant eligible or ineligible. So first we look at the risk categories, and this is evolving, but these are a number of chromosomal abnormalities that can be seen at baseline. And based on that, we can divide the patients into high or standard risk disease. And again, this is an evolving thing. We're getting better at identifying those risk factors, but for our current purposes and users, this is an excellent algorithm. So for high-risk multiple myeloma, if the patient is transplant eligible, the goal is to do an upfront stem cell transplant. So they get 3 to 6 cycles of induction treatment. Which regimen to use, it varies, and there are no head-to-head trials to clearly guide, but physicians have their own preferences. And of course, we also look at the patients, their age and comorbidities. So patients get 3 to 6 cycles of induction, followed by stem cell transplant, followed by maintenance. And the goal is to achieve the deepest possible response as early as possible. And this is, and to maintain it. And this is especially and particularly important in high-risk patients who tend to have a shorter remission. Similar approach in standard risk patients, which are about 70 to 80% of all myeloma patients at diagnosis. So those who are transplant eligible, again, get 3 to 6 cycles of induction treatment. Which regimen, that is debatable, but there are some very good options that are available. And then one can, again, discuss early or delayed transplant. In high-risk patients, early transplant is generally the goal. In standard risk patients, patients may choose an early transplant, or a physician may choose an early transplant. And there are pros and cons, and we can talk about those in some of the later slides. So again, those who choose early transplant can proceed to an autologous transplant followed by maintenance treatment. And those who choose delayed transplant, one after their 3 to 4 cycles of induction, we collect their stem cells, and then they go on to get the same induction treatment for a few more cycles, and then to maintenance treatment, with the understanding that high-dose therapy and transplant will be performed at the time of disease relapse. So a couple of things about the choice of induction therapy. Now, this is some thing where one can debate because there are not many trials, especially randomized trials, to guide one's choice. But based on what is available and the history and preference, we have a lot of good options available. So if you look at the practice in United States, I think the most common regimen that is used is VRD, bortezomib, lenalidomide, dexamethasone. And we have looked at our data set at MD Anderson, and most of our patients have received VRD as induction in the last decade or so. There are some physicians, there are some myeloma experts who prefer KRD, although if you look at a recent randomized trial from Alliance and ECOG Endurance compared the two combinations in patients without intention to go to early transplant. The results were pretty comparable. So one can choose depending on one's preference or patient's comorbidities. Bortezomib is associated with neuropathy. So if someone has existing neuropathy, one can use carfilzomib, which is the K here, or if someone has cardiac issues where carfilzomib may cause more problems, one can use bortezomib. Patients who have renal failure. In those situations, again, I'm talking about mostly United States, where all these drugs are available. One can use VCD or CyBor-D regimen to avoid lenalidomide because cyclophosphamide is better tolerated in patients with acute kidney injury. Another option on this combination of daratumumab, lenalidomide, and dexamethasone, or DRD regimen, which has been tested in transplant-ineligible patients as well as relapse refractory patients, and is a good combination. And now many myeloma experts are moving towards 4-drug regimen because it achieves deeper responses, although some may argue that it increases the cost, increases the side effects, and may not be necessary for every patient and perhaps should be used for high-risk patients only. But that is something that is going to be debated, and we will see how it will eventually turn out, but it is another reasonable induction option that is available to our patients. And in this slide, what I'm trying to highlight is that even with these newer induction regimens, when they are used in combination with stem cell transplants, the outcomes have only improved. And I'm going to highlight the so-called Forte trial published in Lancet in 2021. A subsequent publication focusing on high-risk patients was also recently published in Lancet Oncology. But in this trial, Dr. Guy et al. Basically compared, and I'm going to focus on 2 arms of this study. It was a 3-arm study. So patients received induction with KRD followed by stem cell transplant, and then consolidation with 4 cycles of KRD, or they just went on to get 12 cycles of KRD. And then they went on to get maintenance. Maintenance was randomized between KR versus R, or carfilzomib and lenalidomide versus lenalidomide only. So what this trial showed, that 1-year MRD negative, the deepest possible response in that trial by multi-parametric flow cytometry, where 1 in 100,000 cells could be detected. There was a better MRD negative response with KRD plus transplant, 47% versus 12 cycles of KRD. Again, showing that if you combine high-dose therapy with melphalan and autologous stem cell transplant with KRD regimen, which is a very potent combination, we can get deeper responses. And because of that, there was also an improvement in progression-free survival. Patients who got KRD plus transplant, their median survival had not been reached with the latest follow-up, versus 55 months, or about 4.5 years, in those who received 12 cycles of KRD and went on to get maintenance treatment. However, as we have seen with most myeloma studies, with better overall survival for our patients, there is no significant difference in overall survival at 4 years. But if you look at the conclusion that even with KRD regimen, when it is combined with stem cell transplant, there was superior 1-year sustained MRD negative results, as we saw here, and progression-free survival with KRD plus transplant versus KRD times 12. Another question, we talked about the 4-drug regimen. So if you look at the second trial here, the so-called Griffin trial, published by Dr. Voorhees in Blood in 2020. So in this trial, basically patients received either a 3-drug induction, VRD, or a 4-drug induction regimen, followed by autologous. So this is everyone received an auto transplant. Question was 3 or 4-drug for induction and consolidation. And then those who received the DARA VRD also received 2-drug maintenance. And what it showed again was that those, and which is what intuitively, one would expect that if you combine 4 active drugs, you're going to get better responses. So stringent complete response rate was higher with DARA-VRD, 42 versus 32% at their first evaluation. When they looked at the final responses, again, it was better with 4-drug regimen, 62% versus 45% in the 3-drug regimen arm, and also MRD negative status at 10 to the minus 5th level, or 1 in 100,000 cells detectable, was significantly better with 4-drug regimen. With their short follow-up of 2 years, there was no significant difference in progression-free survival. But again, if you look at the study, it's showing that 4-drug regimen is achieving deeper responses in these patients. And because of that, many centers are using 4-drug regimens, and many physicians, and especially in high-risk patients, because the goal is to achieve as deep a response in these patients and maintain that deep response. All right, switching gears. Since we are talking about stem cell transplant, I just want to talk a little bit about stem cell mobilization, because we need those stem cells to do the stem cell transplant. So this is another area where we have made a lot of progress. And basically, the way we mobilize these stem cells normally, here's a stem cell, it sits in the bone marrow, anchored to the bone marrow by a number of different molecular interactions. And 2 main molecules that we use, GCSF and plerixafor, basically disrupt these interactions, and especially plerixafor, that disrupts the interaction between chemokine receptor CXCR4 and the stromal cell-derived factor in the bone marrow microenvironment, and releases the stem cells. So when we collect or mobilize these stem cells, these are the different approaches that we use. Most common is the combination of is GCSF plus plerixafor, where GCSF is given for about 4 days, and then some centers use plerixafor only if they do not get adequate collection, and others use in time or a plan that after 4 doses they give plerixafor. There are pros and cons. Plerixafor is an expensive molecule. If we use it in everyone, it increases the cost, although it may improve the yield of stem cell collection. But if you do it only if we do not meet the target number of stem cell in the blood, then one may save cost significantly. There are some centers that use chemotherapy plus growth factors for stem cell mobilization and collection. The potential benefit that in those patients who have had suboptimal response to their induction, chemotherapy plus growth factor helps in reducing the disease burden. And in those patients where we are unable to collect adequate number of cells, chemotherapy plus growth factors can overcome that issue and allows us to collect stem cells even in those patients. However, giving additional chemotherapy with growth factors has not shown any improvement in progression-free or overall survival. And although we do collect more cells with chemotherapy plus growth factors, they are not necessarily better quality cells, and they do not necessarily improve the timing to engraftment, which has been shown by a number of smaller studies. So the next issue after stem cell collection, we talked about high-dose melphalan. And this has been the gold standard for 30 plus years in myeloma transplants. And we and others have always asked this question, can we do better than that? So with that, a little background, the current gold standard of melphalan given 200 milligram per meter squared, just a single dose in 1 day. This was set after a couple of randomized trials, one where melphalan 200 was compared to melphalan 140 plus total body radiation. Bottom line, melphalan 200 came out safer and more effective. Another study where this was compared to a lower dose of melphalan, again, better results with melphalan 200. So based on these, this is considered the gold standard for transplant conditioning regimen. Several other regimens have been tried. There are a few at MD Anderson. We published thiotepab, busulfan, and cyclophosphamide. Was a phase 2 trial, topotecan, melphalan, cyclophosphamide. These are older combinations. Bottom line, none of them really showed any significant benefit over historic data with melphalan alone. But then we did this randomized phase 3 trial of busulfan plus melphalan versus melphalan alone. After some initial reports from the Spanish myeloma group that this combination may lead to deeper responses and longer progression-free survival, and some preclinical data from my colleague Bore Anderson's lab showing synergistic effect of two drugs against different malignant cells. So I'm not going to go into the details of this study. It was a randomized trial only done at MD Anderson, and more than 200 patients were treated, about 100 in each arm, 104 in bu-mel, 98 in melphalan, as one would expect in a randomized trial. Those patients were pretty evenly matched across both arms. In terms of induction treatment, as I was referring to, 60% of patients received VRD as induction, and then there were other regimens. It was not part of the trials. It depended on what the treating physician wanted to use. And then same thing with maintenance post-transplant. About 85% patients received maintenance, and in most of them, lenalidomide alone was the maintenance therapy for everyone. As you would expect with two-drug regimen, there was more toxicity. So we saw more dysphagia or mucositis with bu-mel. We saw more transaminase elevation, and we saw more neutropenic fever. However, diarrhea was seen more with melphalan 200. And in terms of outcomes, there was no difference in non-relapse mortality, which is what you would expect in myeloma autologous transplant these days. And second primary malignancies with the follow-up that we had was not any different, because the concern was that with two alkylators, this would be higher. This may change with a longer follow-up, and we will be reviewing our data for that. But what was the most important finding from that study was that patients in the bu-mel group had a longer progression-free survival. It was 64 months when it was reported versus 43 months in the melphalan group. Although there was no significant difference in overall survival with the follow-up that we had, which is also consistent with what we see with myeloma studies. So the conclusions from that randomized trial, which was published in Lancet Hematology, was that in comparing these two conditioning regimens, bu-mel was associated with a significantly higher rate of grade 1 to 3 mucositis, transaminase elevation, and neutropenic fever. But there was no significant difference in 100-day or 1-year non-relapse mortality, a significantly longer progression-free survival, which was preserved after adjusting for the maintenance therapy, and a significantly longer progression-free survival in high-risk patients, and no significant difference in overall survival. We did a subsequent analysis from the trial on high-risk patients, and again, with a slightly longer follow-up, we consistently saw a longer progression-free survival in high-risk patients versus but no significant difference in overall survival. And because of that, at least at our center, patients with high-risk chromosomal abnormalities, especially if they are younger than 70 and they are otherwise fulfill the criteria for transplant eligibility, we try to use busulfan plus melphalanus conditioning in those patients only. Of course, we would like to see an improvement in overall survival before we can say that it's generalizable to standard risk patients as well. A couple of slides on another important component of transplant is maintenance therapy. So of course, in good old days, we would do the transplant and then treatment would stop, and that would actually help patients' quality of life. But the median progression-free survival, as you saw in that study from 1996, was about 2 to 2.5 years. So there would be early relapses. So when lenalidomide came out, a number of maintenance trials were started. And the hypothesis was that the use of post-transplant maintenance would eradicate the residual disease and prolong the duration of remission. So here is a summary of a number of trials that were done. So these two trials were reported back to back a little over a decade ago in New England Journal of Medicine, a European or French study, and this is the US intergroup study, and we participated in that. And both these studies showed that compared to placebo, maintenance with lenalidomide improved progression-free survival. The European study did not show an improvement in overall survival. The US study did, perhaps due to longer duration of lenalidomide in the US study. And one striking thing that was reported in both the trial was second primary malignancy that was seen more commonly in those who received maintenance treatment with lenalidomide. Similar results then were shown by trials from Italy, Dr. Palumbo and colleagues. The study was published in New England Journal of Medicine. And then the UK myeloma group did their trial of lenalidomide versus placebo, also showing similar results with longer progression-free survival with lenalidomide. On the bottom, I just referred to ixazomib versus placebo study, which also showed an improvement, but not to the extent that we see with lenalidomide. So based on this, maintenance treatment with lenalidomide has become the gold standard for maintenance in all myeloma patients, with the exception of some ultra high risk where some physicians use combination of two drugs based on at least the data from two trials, Forte trial or Atlas trial that used carfilzomib or a PI-based maintenance in combination with lenalidomide and showed an improvement. So conclusions for maintenance, that post-transplant maintenance with lenalidomide is considered standard of care with an improvement in progression-free survival in all trials and overall survival in at least one trial, as well as in a meta-analysis of 3 trials. And the duration of maintenance is still being investigated. In the US, the trend is indefinite. At least based on the French study, they use 1 to 2 years of maintenance, and now more and more people are looking at MRD guided, that if someone has achieved a sustained deep response, can we safely stop maintenance treatment? And there are ongoing trials addressing the question. There is clearly an increased risk of second primary malignancies, including a study done at MD Anderson by my colleague Koichi Takahashi showed that there is an increase in p53 mutated treatment-related myeloid neoplasms. And bortezomib and carfilzomib-based maintenance may improve outcomes in high-risk patients, and this was part of the guidelines that I alluded to earlier in my talk. So another very important question, which our patients ask, which our colleagues ask, timing of early versus delayed transplant. Early meaning after induction, go straight to stem cell collection and transplant, or just harvest the stem cell and consider transplant later. Important questions. I don't think we have very clear-cut or definite answers. So I would highlight a couple of trials that ask that question, and I would focus on the determination trial. So this is the French IFM 2009 study published in New England Journal of Medicine in 2017, and almost similar study design, the Dana-Farber and then the US intergroup study, also published in New England Journal of Medicine 5 years later. They both had 700 plus patients. They both looked at early versus delayed transplant. They both looked at total of 5 cycles of VRD plus autologous transplant plus lenalidomide maintenance versus 8 cycles of VRD and maintenance treatment. The maintenance in the French study was for 1 year, went up to 2 years, and in the US study until progression. So in the US study, or the determination trial, which was published in New England Journal last year, it showed that those who had upfront transplant had higher CR rate and greater MRD negative status by next generation flow cytometry at 10 to the minus fifth, or where the sensitivity of the assay was that it could detect 1 in 100,000 cells. 54% patients in the transplant arm achieved that versus 40% in the non-transplant or delayed transplant arm. And more importantly, the progression-free survival in early transplant arm was 67.5 months, or more than 5.5 years, while it was a little less than 4 years. So almost a 2-year prolongation of progression-free survival with upfront transplant. And this was even more remarkable in high-risk patients, where it was 55 months or 4.5 years, which is excellent based on historic data in high-risk patients. And those who did not get an upfront transplant, it was less than 1.5 years or 17.1 months. Again, at 5 years, there was no significant difference in overall survival. So again, even in this trial that was reported last year of early versus delayed transplant, we saw a 21-month improvement in progression-free survival. Now, in terms of getting transplant at relapse, in the French study, almost 80% received transplant at relapse, while in the US study, only about 28%. But even with that, it tells us about the effectiveness of drugs and the options that are available even after relapse, that the overall survival was still the same in the US trial and the determination trial. So conclusions, and we can debate these conclusions, early versus delayed transplant, that upfront autologous transplant can be used if the goals are to achieve the deepest response, including MRD negative status. If the goal is to achieve a long progression-free survival, and for some patients, it is very important. For others, it's not. So we do have those discussions. Upfront transplant may be preferable for patients, especially with high-risk disease, where there is a greater chance of achieving MRD negative status, and these patients do worse once their disease relapses. So anything to achieve a deep remission and keep them in remission. Another thing that I think is important, patient's age. So if patient is transplant eligible and prefers and wants to do more aggressive treatment. So for older patients, older than 65 who are transplant eligible, it's perhaps better to do it when they are relatively younger than when they are older and have comorbidities that may preclude them from getting that treatment. So again, these are the discussions that we all have with our patients, and then make decisions based on patient's age, comorbidities, preference, and several other factors. So with that, the last part of this is a few slides on immunotherapy, because of course it is here, it works. So a high-dose melphalan and auto transplant can also be a platform for immunotherapy, because until we find complete cure, that someone gets induction treatment and one dose of an immunotherapy and are cured. But as long as we are doing treatment sequentially, perhaps we can combine an effective immunotherapy with a tried and tested treatment like autologous transplant and achieve an even deeper response and hopefully and possibly cure. And as you know, for immunotherapies, we have these antibodies, we have bispecific T-cell engagers, we have cellular therapies. So teclistamab is already approved by the FDA. 2 CAR T cells, ide-cel and cilta-cel, are already approved. And then there are other type of cells. And in my department, my colleague Katie Rizvani is developing her NK cells for different diseases. And then there are antigen-specific T cells. So we did a phase 2 randomized trial, and this was, of course, more than a decade ago when we started this trial, and the field has obviously advanced significantly. But these were antigen-specific T cells. These are not CAR T cells. They were not genetically engineered or genetically reprogrammed. These were just expanded T cells that were expected to target myeloma cells. So we did this trial where we used a myeloma vaccine, idiotype vaccine made from patients' M protein. And then this vaccine was supposed to stimulate the immune system so that we could collect T cells, harvest T cells, which we thought would target myeloma cells better. And these T cells were then expanded in the lab while patient received high-dose melphalan and autologous stem cell transplant. And then they received their activated T cells about 2 days after transplant. And then they got additional doses of vaccine to boost the immune response against myeloma by using the same vaccine and making these T cells more active. And this was a 2-center trial. We did it in collaboration with colleagues at University of Pennsylvania. We saw some positive changes in immune system, upregulation of genes associated with activation, effector function, induction, memory CD8 T cell generation by gene expression profiling. We also saw increased cytokine production by CD4 positive T cells in response to this autologous vaccine and T cells. But the conclusions were that these autologous T cells, which were activated ex vivo and primed against myeloma vaccine, could be safely infused. They were not toxic, but there was no significant benefit either. After a median follow-up of 1 year, no significant difference in outcomes between those who received the activated cells against the myeloma vaccine versus those who got T cells without any activation against myeloma vaccine. So, but this was more of a proof of principle that T cells can be given to these patients. And now that we have much more effective T cells, perhaps we may improve upon these outcomes in subsequent studies. There are some ongoing cell therapy studies, either comparing CAR T cells with stem cell transplant, and one of the more important ones is CARTITUDE-6, where patients would be getting induction treatment with 4-drug regimen, followed by cilta-cel, a CAR T cell, followed by lenalidomide maintenance, versus same induction, stem cell transplant and len maintenance. And then there is another trial, KarMMa-4 trial, using ide-cel, but this is not in comparison, but this is instead of transplant in patients with high-risk multiple myeloma that are newly diagnosed. So with this, I would like to come to the final 2 or 3 slides. So first, based on what I just described, is there a future for transplant in myeloma? So high-dose melphalan, although very effective, is basically an alkylating agent. It causes DNA damage, DNA strand damage, so rather indiscriminate killing of cells. But so far it has worked. However, with the emergence of targeted immune and cell-based therapies with fewer side effects, similar or higher efficacy, it may be replaced by safer and hopefully more effective therapies in the future. However, let's wait for that high-quality evidence to emerge before you change your practice, because as you've seen, it has worked very well, and it's pretty well tolerated in those who are eligible for that, with some very good results. Of course, there are problems, and we cannot treat every patient the same, but those who are eligible, it is still a very good option. Another important point, that since the original report of high-dose melphalan and transplant, the median progression-free survival, as you saw, has improved from 4 months to more than 5 or 6 years in most of the studies today, and it's expected to get even better if we are using 4 drug induction regimens and more maintenance treatment and better salvage options, or perhaps incorporating some of the newer agents in this. Of course, that's a different debate, the toxicity, the risk of infection, and the cost and sustainability of those treatments. But all this progress that you saw and that has come is due to better understanding of disease biology and supportive care, incorporation of newer and active anti-myeloma drugs, including proteasome inhibitors, immunomodulatory drugs, anti-CD38 monoclonal antibodies, and the future availability of highly effective immunotherapy approaches like CAR T cells and T cell engagers may further improve the outcomes in the future. Speaking of future, and you hear about many things and people giving forecast on what the next treatment would be, I basically, as a skeptic, have this slide to show. This is based on the work by Philip Tetlock, a professor of psychology and political science at Wharton. He's the author of this book called Expert Political Judgment and Super Forecasting. This is a book about political forecasting, but similar conclusion may be applied to many different fields. And whenever someone is predicting the future, the conclusions were experts are not any better at predicting future events than dart-throwing chimpanzees. And there was an inverse relationship between the accuracy of an expert's predictions and his or her self-confidence, renown, and depth of knowledge. And I can say that because when I was 20 years ago, starting my faculty career at MD Anderson, interest in stem cell transplant for multiple myeloma, and that was the time when both bortezomib and lenalidomide had clinical trials, and there were multiple people who had told me that I should do something else because the time for transplant in multiple myeloma is over. That was 20 years ago. So again, we have come a long way, and one day we may not have to use alkylating agent to treat myeloma, but wait for those data to emerge and don't just believe in every forecast. So with that, I would like to acknowledge all my colleagues at MD Anderson and at other institutions who have made this work possible. And of course, biggest thanks to all my patients who have made all of this work possible and have participated in so many of these clinical trials with graciousness and with generosity. Thank you very much for your attention.
Thank you so much, Dr. Qazilbash, for this wonderful presentation. It's certainly very intriguing to hear about these treatments and regimens and how they can be differently implemented. So thank you so much again for this incredibly informative presentation. I will now be passing the mic to Madhuri to moderate our question and answer portion of the day.
Thank you so much, Lexi, and thank you so much, Doctor, for this wonderful presentation. I truly learned a lot on stem cell transplantation and as well as multiple myeloma. So I would like to say welcome everyone to Discussions with Global Leaders. Today we have with us Dr. Muzaffar Qazilbash, who is the Director of the Myeloma Transplantation and Cellular Therapy at the MD Anderson Cancer Center. And today he has discussed with us some of the updates in multiple myeloma therapeutics, as well as some things about stem cell transplantation as well. And I hope everyone enjoyed the presentation. For the first question, I'll be passing the mic to Dr. Yan.
Thank you so much. And thank you so much to Dr. Qazilbash for an amazing presentation, for taking time to speak on our platform. Really enjoyed the thoughtful and insightful information. You are one of the forefathers of the field, so it's an honor to have you here. My question stems around the topic of cell and immunotherapeutics. We've seen the profound impact that they have made in the hematological malignancy space, specifically in lymphomas. And now they have shown progress in multiple myeloma as well. There are in production and in the pipeline off-the-shelf cell therapies and NK cell CARs. So this is kind of a two-pronged question. What are your thoughts on the potential of these therapies? And do you feel that with further modifications, their efficacy could be up to par with the present CAR T cells that we have and or of transplant? And then my second question is, sometimes these therapies sometimes patients don't respond well to these therapies. Do we know why? Is there molecular or genetic explanation for this? Thank you so much.
All right. Yeah, great questions. Thank you very much. Of course, as you've seen that it's been a revolutionary period when it comes to immuno and cellular therapies, especially in hematologic malignancies. Of course, on the solid tumor side, we have the checkpoint inhibitors, and in the hematologic malignancies in the landscape of lymphoma, as now you know that CAR T cells are potentially curative and have become a new standard of care for patients in second line who have not responded to their salvage treatment based on the recent clinical trials. So there is no question that these are very effective treatments, and they've really made tremendous progress. And multiple myeloma were a little behind because those trials are starting to come out. So of course, we have two products that are approved by FDA. They're both effective with the response rates that were unprecedented and unheard of just a couple of decades ago for relapse refractory patients, and now with a single dose of ide-cel or single dose of cilta-cel, anywhere between 70 to 95% plus patients are responding. So yes, I am very excited about those results, but are we there yet? We still need to see the follow-up. We still need to learn more about the toxicities. We still need to see how best to incorporate them in our treatments, because some of them are now moved up in the treatment schema also. At least one product, ide-cel, there was a clinical trial that was reported, but we have not seen the durable response or the plateau and survival curve that we have seen with in lymphoma. So bottom line, CAR T cells in multiple myeloma are highly effective, are going to be there in the future. But so far, we have not seen the curative effect of CAR T cells, but that doesn't mean it won't happen. These are living drugs which are going rapid modification, and we will see that. Just to answer your second question, yes, those things have also been worked out, why some patients respond and others don't, or even if they respond, the response is transient while others have, and it has to do with both inherent factors in the disease, then of course how these tumor cells adapt, the resistance mechanism, losing the target antigen, or exhaustion of the T cells, or the quality of the T cells that were collected. And that's where some off-the-shelf T cells, because so far most of these cells have been obtained from the patients themselves who have had a lot of treatment before, which may have severely suppressed their immune system. If we could get those cells from normal donors, like off the shelf NK cells and all, would that make a change? Again, clinical trials are ongoing, and we will learn, and hopefully we'll have answers with all the correlative studies that are also ongoing in the laboratories.
Thank you so much. Really appreciate that thorough response.
Thank you, Doctor. That was honestly a wonderful answer, and definitely looking forward to more. For our next question, I'll be passing the mic on to Lexi.
Yes, thank you again. So you touched on this briefly, but my question is, what are you most excited about in the future of myeloma?
Sure. So, as someone who's been in this field long enough, so changes are incremental and gradual. So we've seen that anything that comes out generates a lot of excitement, but then with emerging data on toxicity or a longer follow-up, things don't look as glittering as they did when they first come out. Having said that, I think for multiple myeloma, as you've seen, and the numbers speak for themselves, the biggest excitement are these bispecific antibodies and CAR T cells, the immuno and cellular therapies. They both have their pros and cons. We were talking about off the shelf. The bispecific antibodies are available off the shelf. You can write a prescription and patient can get that. Of course, they have to be given in special settings, and there is careful things, and there are precautions and preventive measures for infections and for immunosuppression. So those things have to be done, and they have to be given repeatedly. So but they are off-the-shelf products. So that's the advantage of bispecific antibodies, and I'm excited about those. I'm also excited about CAR T cells because from the patient standpoint, it is a one-time treatment, and so far both the approved products are given once, and there is not even maintenance treatment. And it is of enormous importance to our patients who don't have to keep coming back for their next cycle or injections or waiting in the infusion centers. So I'm excited about both these products, both these group of drugs, but we just have to see how we incorporate those in future treatments. So there's still a lot to learn.
Thank you.
Thank you so much, Doctor. And that was honestly a wonderful answer. And I'm really looking forward to the promising future in multiple myeloma. So for the next question, I would like to ask, as you had mentioned, stem cell transplantation has definitely improved the survival rate in multiple myeloma, but there are still many individuals who are unable to collect optimal CD34 hematopoietic stem and progenitor cells with GCSF mobilization. So how can we help to mobilize this situation for autologous stem cell transplantation in multiple myeloma?
Sure. Yeah, so good point. So I did highlight some of the things. So we started out, there's a history. We started out collecting bone marrow stem cells, and then, of course, studies were done that showed that these stem cells can actually be mobilized from the bone marrow into the peripheral blood, and GCSF could do that. So that led to GCSF, and then came plerixafor. So GCSF plerixafor is currently our best combination, and it has significantly improved the mobilization and collection of stem cells, especially if we collect them early, like after 4 to 6 cycles of induction. But with 4 drug regimens and delaying transplant and not coming for stem cell mobilization may make it difficult. So again, in addition, there is a new drug called metexafortide, which is also a CXCR4 inhibitor. It was published in Nature Medicine, and that looks very promising also in terms of improving stem cell mobilization when it is combined with GCSF. And then in some patients, if we think that this patient is not going to mobilize well based on prior history of treatment and the number of treatments that they've received, I recommend using chemotherapy plus growth factors upfront to mobilize these CD34 cells. And it would be good because one of the complications of CAR T cells is prolonged cytopenia. So if we can harvest these stem cells and use them to overcome that low blood counts in these patients, that would be beneficial.
Thank you so much, Doctor. And that was really great to learn about as well. And I was really looking forward to learning more on it. So for our next question, I would like to pass the mic to Rabab.
Hello, Doctor. Thank you so much for the amazing presentation. It was really interesting and knowledgeable. So my question to you was, how do you foresee the diagnostic approaches being evolved in healthcare with respect to myelomas? And my second question would be, what advancements in these approaches do you think will lead to better treatment options in the future?
Sure. So, in terms of diagnosing the disease, we do have very good ways. Bone marrow biopsy remains the gold standard, but in myeloma, we also have the advantage of doing blood and urine tests to detect the myeloma protein or monoclonal or paraprotein. We also have imaging studies because, as you know, about 2/3 to 3/4 of these patients can have bone disease also. So we used to do bone x-rays, but now with advanced imaging like whole body MRI and PET scan, we can detect those bone lesions early. So advancements in imaging, advancements in molecular studies has helped. Then other important things is not just making the diagnosis, but also stratifying patients into different risk categories. And that's where chromosomal abnormalities or gene expression profiling would help identifying patients who are at greater risk or who are high risk versus standard risk, because then we can tailor the treatment accordingly, that a high risk patients probably need more aggressive treatment up front, and a more standard risk patients may receive less aggressive treatment over an extended period of time. So I think these advancement in molecular studies and imaging studies will help the diagnostics. Another important thing, although it's not diagnostic, are these detection of minimal residual disease. And I alluded to that in my presentation by flow cytometry or next generation sequencing, because that helps us in determining if the patient has completely cleared the disease. And once we find that out, we can tailor our treatment or tailor stopping treatment accordingly, that if someone has received the treatment and with the most sophisticated testing, we do not detect any disease, then in those patients, we may stop their maintenance treatment and give them a treatment-free interval. So I think these are the different diagnostic approaches that would help us in better treating our patients in the near future.
Thank you so much, Doctor.
Thank you, Doctor. That was a wonderful answer. And for our next question, I would like to pass the mic to Harshal.
Thank you, Doctor, for this insightful session. So my question is, given your expertise in leading clinical trials in multiple myeloma, could you shed some light on the challenges faced in conducting this trial and bringing new therapies to the market? And how do you ensure patient safety while striving for innovation?
Yeah, well, as you know, doing clinical trial is difficult. It requires a lot of work. It requires a team. So if I want to do a clinical trial today, I have to write a protocol. I have to have a research nurse. I have to have the budget to pay for the person who collects data, a research nurse who would help in consenting. And I'm talking about just a single institution study, and then have to have people who would discuss the informed consent with me, with the patient, and of course, if I am using a new drug, I have to obtain that drug or pay for that drug. And then, any clinical trial requires a lot of personnel as well as a lot of money to do. And you also require statistical support and IRB support. So there are challenges, but again, there are institutions that have developed those programs over the years, have invested in those, and that has helped. Of course, on the other side, there are our pharmaceutical colleagues who have developed a new drug and they want to do large clinical trials, and they have done those successfully. There are pros and cons to every approach. If we are doing as an investigator-initiated trial, we feel that we are more unbiased in our approach, as opposed to if I have a particular product that where I have invested a lot of money in developing, and my goal would be to basically get the FDA approval and then take it to the market. So there could be some challenges there as well. But the bottom line that clinical trials can be done anywhere, but you need infrastructure, you need funding, you need investment from your institution or the right people to conduct that, who realize the importance of those clinical trials, that what we know today, what is the standard of care today, became standard of care because someone conducted those clinical trials and showed scientifically that this is the best treatment to use at this point.
Thank you, doctor, for your answer.
You're welcome.
Thank you so much, doctor. That was really great to hear about as well. So for our next question, I'll be passing the mic on to Muskan.
Hello, Dr. Qazilbash. First of all, thank you for such a wonderful presentation. I truly learned so much, and it was truly awesome listening to your presentation and the work. So, doctor, my question really was, COVID and multiple myeloma overlap in the fact that they both cause a hypoxic condition and lead to ARDS. So, how does the prognosis and survival differ in patients with multiple myeloma who get infected with COVID, and compared to patients with just COVID and they are not suffering from multiple myeloma? And are there any difference in the treatment modality? So we have the standard of care that we would perhaps use in severe COVID patients. How do you think, and what are the differences in the treatment you would use for patients with multiple myeloma suffering from COVID? Thank you so much.
Yeah, no, thank you for your question. So, these are two different diseases, but unfortunately, multiple myeloma patients, like any cancer patient or patients who are receiving chemotherapy, are prone to get infections, and COVID is an issue in myeloma patients. And there were studies that were done because these patients are immunocompromised, they could get COVID and may get. But in terms of treatment, we don't have to change our treatment strategies for multiple myelomas. But if I have a patient with myeloma who has COVID, my first goal would be to treat that underlying infection because it may just be I have a lot of patients who had COVID, but if in most patients, it was a self-limiting thing. We treated them symptomatically, and once their infection cleared, we resumed their anti-myeloma treatment. Or patients with COVID, if they developed symptoms, then they were and they required treatment, we gave them anti-COVID-19 treatment. And once they recovered, then resume their anti-myeloma therapy. So again, I would first treat the infection and then wait for the infection to resolve before I would resume treatment for multiple myeloma, because otherwise I would only add to toxicity. I would definitely hold anti-myeloma therapy in someone who's in the ICU with ARDS.
Thank you so much, Dr. Qazilbash.
You're welcome.
Thank you so much, Doctor. That was truly interesting to know about and to analyze these situations as well. That was a really great answer. Thank you. So unfortunately, we've come to our last question for today, and I will be passing the mic to Jenna for this. I can ask our last question. Sorry for that. So for our last question, especially for our junior attendees who are just getting into research and medicine, what inspired you to pursue the field of multiple myeloma and stem cell transplantation and more? And how has this choice impacted your life? Has it been everything that you initially anticipated?
Well, it's a loaded question. Thank you. I think we all, after a while, build a narrative. I think many things in life happen randomly. You just stumble on them. You're lucky to have some good opportunities. And also, I think, I can tell you a few things about myself, that I was interested in becoming an oncologist. And when I got into a hematology oncology fellowship at NIH in the early 1990s, that was the time when there was a lot of interest in gene therapy, and stem cell or bone marrow transplantation was considered a very hot area. So I got interested in that. And then and some of my mentors at that time were interested in treating that disease. So I was inspired by them, because if you see someone who you would like to become one day, you somehow develop interest in things that they are doing. So that was basically the development of my interest. When I came to MD Anderson, again, I had the opportunity to do stem cell transplantation in multiple myeloma, because I was given that opportunity by my chair, Dr. Champlin, and my friend and colleague, Dr. Sergio Geralt, who's now at Memorial Sloan Kettering. And then I worked closely with my colleagues in the Department of Lymphoma and Myeloma, Dr. Orlowski and others whose names you see here, who also helped me in basically developing my expertise in treating these patients. And then, of course, another very rewarding thing is to work with your patients, to take interest in their stories. You can learn a lot from that. And then they also ask some very intelligent questions about the disease, which forced me to read more about that, and which obviously one thing led to the other. And I just built a career in that. And if you are working in an academic center like MD Anderson, everyone is more or less involved in clinical research with great mentors. And that was my training to be a clinical researcher. So it's a number of things, and some luck and some hard work, and you become whatever you want to.
Thank you, Doctor. Honestly, that's really interesting to hear about. And I hope that in the future, we can also meet amazing mentors as yourself and even work with you as well. So thank you so much for today's presentation.
Thank you. It was a pleasure.
Okay, thank you so much, everybody. And